recording will be start in 3, 2, 1. Please start.
So I
Yeah,
welcome.
good evening.
Yeah.
Yeah,
So just an introduction of the speakers, then we'll hand over to
sure,
you, sir.
sure.
So I welcome in this evening's session on prostate cancer updates, clinical conversation on prostate cancer update. So today we'll be having two sessions, and the speakers are very well known. Hasn't required any introduction, but still it's a formality. So our first speaker will be Dr. Kushal Gupta. Sir is the professor and head of Department of Medical. Sir will be speaking on reaching new heights in MHSPC care. Over to you, sir.
Yeah, thank you, Orno, for the generous introduction. And we'll be touching upon a very important topic, which is prostate cancer, and we'll be, as you know, that we have had recent advances in the management of the metastatic HSPCs as well as the CRPCs. So, second part of the talk will be taken by Dr. Abhishek. So without further ado, I would ask the organizer to switch on the slides, please.
Sure, sir.
So in this topic, we will be talking about the overall, the sequence of events uh, in the lifeline of a prostate cancer patient. How prostate cancer is initially locally advanced, and then it becomes metastatic HSPCs, and then it becomes CRPCs, and which is the major cause of mortality. And apart from that, that we'll be also be discussing why it is important to. Yeah. So slides are still not on. Yeah. So
Sorry,
and
sir.
apart
It's
from that.
now. Yeah. Sorry, sir. It has now come here. So now
Okay.
I have parked over here.
Okay.
So no problem, sir. I'm
Okay.
sharing my side.
Yeah. So again, we will be discussing about no problem, no problem. So again, we'll be discussing about uh, you know uh, the multiple oral the medications like darolutamide and apalutamide, and we'll be talking about the relevant studies which tell us that why we can interact early to delay the progression of the metastatic HSPCs to metastatic CRPCs, and how it can improve the quality of life also, as well as improve the survival also. So without further ado, let's change the slide to slide number 2. So this is a disclosure from Bayer. Next slide. Yeah, so as we were talking that the prostate cancer landscape starts with a locally or locally advanced prostate cancer, and initially there will be biochemical recurrences and no visible lesions, but slowly these recurrences become more frequent, and patient may start developing symptoms, or it can be the other way around also, that the patient may directly present with a lot of lower unit tract symptoms, and in a locally advanced stage or in a metastatic stage, which is initially diagnosed as metastatic HSPCs. And initially, we treat the patients either with a curative intent, even if it is locally advanced, we treat the patient with a curative intent using radiation or surgery, along with that ADT. And again, in HSPCs, also the treatment more or less remains the same, except for that we omit surgery and we give palliative radiation. Along with that, we use ADTs. And slowly in the life cycle, once the patient progresses to metastatic CRPCs, we use multiple agents to delay to treat it, and we also introduce bone modifying agents in metastatic CRPCs, and then ultimately it becomes a terminal disease when the patient PS deteriorates, and the patient is maybe bed bound due to fractures in the vertebrae and all, and that's how the thing comes to an end. So patients who suffer and die of prostate cancer all have CRPCs, and treatment of metastatic prostate cancer overall improve survival improvement of only 2.5 to 4.5 months. So the crux of this talk is how can we delay the uh, diseases like metastatic hormone sensitive prostate cancer to progress to CRPC. Next slide. So yeah, next slide. So there is an opportunity to delay the metastatic CRPC and further improve outcome. And not only outcomes, not only the survival outcome, it also will improve the quality of life of the patient. Next slide. If we look at the Stampede trial, that the which was comparing which studied the survival of newly diagnosed metastatic prostate cancer patients in the docetaxel era. So there were data for 917 patients in the control arm of this Stampede trial. So it definitely showed that PFS events were more or less the PFS and the FFS events were improved if if we intervened early. Next slide, please. Yeah, so in the Stampede trial, the prostate radiotherapy for metastatic HSPCs, and in less than four bone metastasis, it was very helpful. And in more than four bone metastasis or in widespread disease, the introduction of prostatic radiotherapy for HSPCs was not very helpful. Next slide. So improving outcomes with systemic therapy, we have a number of trials like JETUG AFU 115. We have the Chartered, we have the Stampede, and then again we have the Latitude, Arches, Titan, Enzamet, and Peace One and Arasens. So we can see that overall, over a period of 1.5 decades, we have seen a remarkable improvement in the overall survival, and all of the trials have been, favored, favoring early introduction, whether it is docetaxel or docetaxel with abiraterone, or enzalutamide or apalutamide, or introduction of the darolutamide in the latest Arasen study. So now we have a wealth of data supporting concomitant therapies, and so now the question comes: what do we choose, and what do we choose intelligently? Next slide, please. Next slide. So is there any technical glitch? Yeah. So next slide, please. So if you look at the use of docetaxel in metastatic HSPCs, we come across the study which of high volume disease versus low volume disease, and in the high volume arms there were docetaxel with androgen deprivation therapy versus androgen deprivation therapy alone. So it showed that the introduction of median overall introduction of docetaxel improved the median overall survival with a significant p-value by almost 16.8 months, which is very, very significant. 1.5 years of overall survival with the introduction of docetaxel is very, very significant. And however, in the low volume disease, the introduction of docetaxel was not quite helpful, and the p-value was also not significant. So we see that the if the patient of HSPC, metastatic HSPC, has got very high volume disease, then it is prudent to introduce docetaxel early along with ADT. Next slide. And then we come across the introduction study of abiraterone in high risk metastatic HSPCs. So come across the studies in which the abiraterone was the first to show that hormonal treatment can be effective. However, it is important to understand that the treatment journey of the control arm when interpreting this data. So we can see that introduction of abiraterone along with docetaxel was also feasible in metastatic HSPCs. Next slide. Yeah, so the problem with abiraterone was its toxicity. Using abiraterone alone was its toxicity with prednisolone, and therefore the introduction of prednisolone came for decreasing the toxicity of abiraterone. So grade 3 and grade 4 hypertension was present in 22%. And other than that, in my experience, I have not had very significant toxicities of grade 3 or grade 4 in abiraterone. Next slide, please. So then we come across the study of apalutamide along with ADT versus placebo versus ADT, a fairly large study of approximately 1000 plus patients in metastatic HSPCs, which showed that there was an improvement in overall survival as well as an improvement in progression-free survival with the introduction of apalutamide with the addition of apalutamide to ADT. And in this was significant in both the groups, which is the low volume and the high volume groups. Next slide, please. And again, we come across a study of using use of enzalutamide in metastatic HSPCs, which again show that there was an improvement in use of enzalutamide with ADT versus non-steroidal anti-androgens with ADT. And this was again a fairly large study of 1000 plus patients, which again showed that introduction of enzalutamide had a significant approval and a significant with a significant p-value in the low volume disease, but the p-value was not significant in the high volume patients. Next slide, please. So what do we do? We have got introduction in for treatment of metastatic HSPCs. One thing is for sure that we have ADTs. The other thing is that what do we do? We classify the patients into high volume, low volume, and then we decide whether we should introduce docetaxel or we go with abiraterone as a partner of ADT, or should we introduce enzalutamide. Next slide, please. So again, we come across a study of usage of abiraterone with in de novo metastatic HSPCs. So this was a study from November 13 to December 2018, and it was the study was randomized into 4 arms in the 1:1:1:1 ratio. Arm A was the standard of care, and Arm C was the standard of care with radiotherapy. And there was this pooled abiraterone group in which the standard of care was combined with abiraterone with prednisolone, and in the Arm D, it was standard of care with abiraterone plus prednisolone plus ADT. So the other inclusion criteria were less than 3 months of ADT prior to randomization and no prior cytotoxic chemotherapy or biological therapy. And the patients were stratified according to their ECOG performance score, the metastatic sizes, sites, lymph nodes versus bones or viscera, and the type of castration, orchectomy, or LHRH agonist versus LHRH antagonist, and whether the patient has got docetaxel, yes or no. Next slide, please. So the combination of docetaxel with abiraterone in the population of high volume disease, which showed a remarkable improvement, but it was not so remarkable in the low volume disease. So this led to the confirmation that in high volume disease, you could improve outcomes by adding abiraterone to docetaxel versus docetaxel alone. In low volume disease, it did not seem to be as beneficial as the high volume disease. Next slide, please. Now again, we come across a very interesting study of darolutamide, which compared usage of darolutamide, introduction of darolutamide in metastatic HSPC patients who received docetaxel with docetaxel 6 cycles along with darolutamide versus placebo. So patients had to be good ECOG PS with candidates for ADT and docetaxel, and stratification was due to extent of disease, M1 versus M1B versus M1C, and alkaline phosphatase levels. And the study endpoints were overall survival. The secondary endpoints were time to castration-resistant prostate cancer, time to pain progression, and symptomatic skeletal event free survival, as well as the time to first symptomatic skeletal event, time to initiation of subsequent antineoplastic therapy, time to worsening of physical symptoms, time to initiation of opioid use for more than 7 consecutive days, as well as the safety. So, and the adverse events, interestingly, between both the arms was found to be identical. Next slide, please. So, if we look at the overall survival data, which was with the introduction of abiraterone arm, it was quite significant. And there was, if you can see that there is a early separation of the curves even up to as early as 4 to 5 months after randomization, there is an early separation of curves, and the hazard ratio was favoring the introduction of darolutamide. And mind you, this is without any significant additional toxicity, because the toxicity rates were significant in both the arms, and we were normal in both the arms. And this overall survival in the overall population was advantageous for darolutamide, which was significant by means of p-value also. Next slide, please. And if you look at the high risk patients, so darolutamide with ADT plus docetaxel, we look at there was a significant advantage in the high risk as well as the low risk patients, and this formed the crux of the introduction of darolutamide in the ARASEN study. Next slide, please. And if you look at the secondary efficacy endpoints, the time to CRPC, the time to CRPC was also prolonged, and there was 64% risk reduction in the progression of patients of HSPC to CRPC, which was again statistically very significant. Time to pain progression was also apparently better in the darolutamide arm, although it was not statistically significant. And this time to subsequent neoplastic anti-neoplastic therapy, it also led to 61% risk reduction with the introduction of darolutamide arm. And then again, the time to first skeletal related events, it was again delayed in the darolutamide arm, but it was not statistically significant. Next slide, please. So if you look at the PSA response and outcomes of darolutamide arm versus ADT alone or ADT with placebo, we see that the patients achieving undetectable levels of PSA much higher in the darolutamide with ADT arm as compared to the placebo with ADT arm, and this difference was quite significant starting from 24 weeks to any time. It was maintained throughout throughout the trial. This difference in the improved number of undetectable PSAs, and the time to the PSA progression was also better, that means longer in the darolutamide arm. And naturally, as we already discussed, that the overall survival, if we can take surrogate as of undetectable PSA at 36 weeks as a marker, then the overall survival are also favorable in the darolutamide arm. And we can say that more than two-thirds of the patients reached below zero point 0.2 in the overall study, so which is quite significant. So 67% of the patients reaching undetectable PSA levels or PSA levels below zero point 0.2 is very significant. That means it totally disrupts the volume of disease if we introduce darolutamide along with ADT with docetaxel. Next slide, please. So again, the PSA response and the outcomes in high volume disease was much more magnified as compared to the low volume disease. We can see that even at 12 weeks, that is just after around 3 months, there was the patient started having higher number of patients started having undetectable PSAs, and this was again interpreted in terms of overall survival, and which showed that darolutamide with ADT with docetaxel had a higher median overall survival, and which is significantly better hazard ratio in favoring the darolutamide arm. So darolutamide triplet achieved longer periods of no disease progression and also significantly improved to overall survival. Next slide, please. So PSA response and outcomes in low volume disease we were talking about. So again, darolutamide arm is the clear winner here. So again, use of darolutamide along with ADT with docetaxel was much more better with a significantly favorable hazard ratios in all the studies. Next slide, please. So if we are deciding between doublet and triplet therapy in metastatic HSPC, first and foremost is that we have to consider that patient able to tolerate. So tolerance of the patient, the performance score of the patients is very important. As you remember that in the Erasmus studies, the inclusion criteria for introduction of darolutamide was PS of 1 or less than 1. So PS of 0 or 1, and patient should be able to tolerate and accept docetaxel also. And the extent of disease we can classify as high volume or risk, and the likelihood of hormone insensitive clones, as well as we have to see the age and life expectancy. And in those patients who have got a expected life expectancy of more than 10 years, we should always hit hard and early, because prostate cancer will be the cause of death in those patients. So especially if we have patients, young prostate cancer patients, or patients in their 60s, we can expect their lifespan to be around 75 to 78. Then we should be very very careful to hit the patients with the best form of therapy early. And the question will be, docetaxel be an obligation in the near future? So we can understand that docetaxel is much less effective post ARPI progression, and patient needs to be informed of all the options. Next slide, please. Thank you. So with this, I conclude my talk. So my take on this is that introduction of darolutamide is very important, and it will help the achieve biochemical negativity, like less PSA, undetectable ranges of PSA early, provided that it is tolerated along with docetaxel. And we should be very very careful, and we should check the fitness of the patients for uh, ability to mm, to tolerate docetaxel. So with this, I hand over my session to the organizers for the next session by Dr. Abhishek Anand.
Thank you, sir. Thank you for your nice presentation. So, if anyone have any questions, they can ask now. They can type in the chat box. So I don't think there is any question as of now. Our next session is with Dr. Abhishek, sir. Sir, are you there, sir?
Yes, yes, I'm here only.
Okay, okay. So our next speaker is Dr. Abhishek Anand. As I have already told that our speakers does not need to record any introduction. It's a formality. Dr. Abhishek Anand is the Director of Medical Oncology in Paras HMRI and Narayana Cancer Center, Patna. So sir will be talking on the advancing AMX treatment horizons, darolutamide without chemotherapy, and aeronautic evidence. Over to you, sir. Sir, should I share the slides from my end, or you will share, sir?
Just 1 second.
Sure, sir. Sir, you are not visible, sir. Yes, yes. Thank you, sir. Thank you, sir.
So, good evening to all of you, and thank you, Bear, for this opportunity. I'll be discussing on advancing metastatic hormone sensitive prostate cancer treatment horizons, darolutamide without chemotherapy, that is the aeronaut evidence. These are the disclosures. So the standard of care in metastatic HSPC has evolved to combine ADT with AR inhibitors, that is abiraterone or docetaxel. And if we see the data we have from chartered trial, that is docetaxel with ADT, then Stampede, which included the arm C of docetaxel with ADT, Latitude, that started combining abiraterone with ADT, then Stampede arm G, again that was abiraterone with ADT. Then came the enzalutamide, that was Arch's study, enzalutamide along with ADT, and Enzamet also, that also included the role of docetaxel in combination with enzalutamide and ADT. And then came the Arason's study, that was darolutamide along with ADT along with docetaxel. And then in 2024, this was the Aranaut study, darolutamide along with ADT, and another study was Arasec study, that was darolutamide along with ADT. So despite the treatment with ARPI, with ADT or docetaxel plus ADT, a large population of patients with metastatic hormone-sensitive prostate cancer will eventually progress to metastatic CRPC within 3 years. So there is an unmet therapeutic need in this subset of patients that remains, and it remains for an efficacious treatment that offers a differentiated and improved safety profile for patients with metastatic HSPC without adding significant toxicities and with a low drug-drug interaction potential. Arasan, which is a phase 3 study in combination with docetaxel, has already showed benefit and in terms of efficacy as well as safety profile in the metastatic HSPC setting, leading to its approval in India as well in 2023. Darolutamide in combination with ADT would provide efficacy benefit with a favorable safety profile in the same subset of patients, that is metastatic HSPC patients, as demonstrated in global phase 3 study Aranaut trial with significant number of patients who were of Indian origin. With the Aranaut study, darolutamide has the potential to change the treatment paradigm, as now it would be the only ARI which could be used with and without chemotherapy. Little bit of background, darolutamide along with ADT with docetaxel is the standard of care for metastatic HSPC patients, and in the Arasen study, darolutamide, ADT and docetaxel did demonstrate favorable efficacy and safety as compared to the ADT plus docetaxel alone. Aranaut was designed to evaluate the role of darolutamide with ADT versus ADT to provide a new treatment option for metastatic HSPC without adding the chemotherapy backbone, that is docetaxel. So this is the study design. Patients with metastatic HSPC were enrolled. Histologically or cytologically confirmed adenocarcinoma of the prostate with ECOG performance status of 0 and 2. Patients were randomized 2:1 to receive darolutamide, that was 600 mg twice a day along with ADT, and compared with placebo with ADT. The primary endpoint being the radiographic progression-free survival, and the key or the secondary endpoints being overall survival, time to initiation of subsequent antineoplastic therapy, time to CRPC, time to PSA progression, rates of undetectable PSA, time to pain progression, safety, and other pre-specified endpoints like PFS2, time to SSE, skeletal related events, time to deterioration of FACT-P score, that is functional and quality of life parameters. Coming to the demographic and clinical characteristics at the time, at the baseline. So if you see here, in the two arm darolutamide along with ADT and the placebo with ADT, it was more or less well matched between the two arms. But the important point is that the Asian population constituted more than 30% in the darolutamide arm, and it was 30% in the placebo arm as well. So major chunk of patients in this trial was Asian as well, which also included Indian patients. If you see the metastasis at the initial diagnosis, de novo 71% and 75%, and at the time of recurrent it was 22% and 20% respectively in the darolutamide and the placebo arm. High disease volume was seen in 70% of the patients in the darolutamide arm and 70% in the placebo arm. So this is the country representation across breakthrough clinical trials for prostate cancer. As you can see here in the different trials, apart from the aeronaut study, India and Asian population were not well represented. And if you see the aeronaut study, 30% of the patients were of Asian origin. So this is something we need to understand, because most cancer do have got the biological diversity, and when we are using in our patients in Indian population or patients of Asian origin, we must remember that the trial, the baseline characteristics of the trial also included the Indian population in this study. So Indian population constituted 13.7% of the overall population in the darolutamide ADT arm, and in the placebo arm it was 14.3%. So a good number of patients were enrolled from India as well. Coming to the results, the primary endpoint, which was radiographic progression-free survival, darolutamide along with ADT significantly reduced the risk of radiographical progression or death by 46% as compared to placebo along with ADT. As you can see here, at the end of 2 years, the PFS rate was 70.3% in the darolutamide arm, and it was 52.1% in the placebo ADT arm, with a hazard ratio of 0.54 and a significant p-value. The benefit of darolutamide plus ADT on radiographic PFS was consistent across all the subgroups, including patients with high or low volume disease. As you can see in this forest plot, irrespective of the baseline PSA values, age subgroups, ECOG performance status, Gleason score, disease volume, race, geographical region, visceral metastasis, and prior local therapy. So all the subgroup favor the addition of darolutamide as compared to placebo. Specifically, the disease volume, it was better in both high volume as well as low volume disease status. It also demonstrated a benefit across all the secondary endpoints, as you can see here. Metastatic time to metastatic CRPC development, time to PSA progression, time to initiation of subsequent systemic therapy for prostate cancer, and time to pain progression. And when we talk about the overall survival data at this time of analysis, this is the primary analysis, and the OS data are still immature. Since OS is immature, patient will be followed for survival further. And regarding the all remaining per protocol placebo patients offered a crossover to the darolutamide after primary analysis. So crossover was allowed in this trial. Darolutamide along with ADT also delayed time to CRPC and time to pain progression, as you can see here in this Kaplan-Meier curve. Darolutamide plus ADT, time to metastatic CRPC median was not reached, and in the placebo arm, the median time to reach metastatic CRPC state was 13.8 months. So it was prolonged in the darolutamide arm, and the time to pain progression was also longer in the darolutamide arm, where it was not reached the median time to pain progression. However, in the placebo arm, it was 29.9 months. Darolutamide plus ADT also achieved a deep as well as durable PSA responses. As you can see, PSA less than 0.2 at any time during the treatment. It was 62.6% in the darolutamide plus ADT arm, and it was 18.5% in the placebo arm. So 63% of the patients in the darolutamide doublet arm attained PSA less than equal to 0.2 nanogram per ml, and this represented a 69% improvement in the time to PSA progression in darolutamide arm as compared to ADT. The time to PSA progression was not reached in the darolutamide arm, and the median time to PSA progression was 16.8 months in the placebo arm, with a hazard ratio of 0.31. A higher proportion of patients achieved undetectable PSA that is less than 0.2 nanogram per ml with darolutamide versus placebo in both high volume and low volume subgroups. So if you can see here, in the high volume as well as low volume, there was a higher proportion of patients who achieved a undetectable PSA level. Subsequent life prolonging anti-cancer therapy. So you can see in this table, patients who discontinued study treatment was 45% in the darolutamide arm and 71% in the placebo arm, and patient with subsequent life prolonging systemic therapy was given to 42% in placebo arm and 32% in the darolutamide arm, and docetaxel was given to 22 and 28% respectively in the daro and placebo arm. Incidences of treatment emergent adverse events were similar between the treatment groups. So, just a second. Okay, have a look.
So, कैसे तो ये सीधा रिवीजन करनी चाहिए.
We'll see tomorrow. कल देखते हैं. Incidences of treatment emergent adverse events were similar between the treatment groups, and discontinuations were lower in the darolutamide arm. And you can see here, any adverse events were seen in 91% of the patient in the darolutamide arm and 90% in the placebo arm. Grade 3 and 4 adverse events seen in 30% and in the darolutamide arm, and it was similar 30% in the placebo arm as well. The median treatment duration was 24.2 months in the darolutamide arm versus 17.3 months in the placebo arm. And the safety profile of darolutamide in the arrow note was independent of the PSA response and consistent with the favorable tolerability first seen in the Aramis as well as the Arasens study. These are the rates of most common adverse events which were low and similar between the treatment arms. As you can see, anemia, arthralgia, UTI, back pain, increased AST level was slightly higher in the darolutamide arm, and fatigue was something which was higher in the darolutamide arm. Rest all was almost similar in the two arms. The rate of adverse events commonly associated with the ARPI were similar across the treatment arms, as in the darolutamide or placebo arm it was more or less similar in the two arms. Hypertension was slightly higher in the darolutamide arm, otherwise all the other major toxicities were more or less similar. Darolutamide confirms a positive impact on health related quality of life as well. As you can see here, the time to deterioration in the FACT-P total score, the median time was 16.6 months in the darolutamide arm, and it was only 11.5 months in the placebo arm. And the darolutamide extended median time to deterioration in the FACT-P score by 5.1 months in total as compared to placebo. Darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression as well as overall well-being. The doublet darolutamide and ADT therapy demonstrates clinically meaningful delays in the deterioration of overall well-being, especially on social, functional, and urinary symptom domain. As you can see here, it was better for the darolutamide as compared to the placebo. So these are the important trials charted that looked after high risk, high versus low volume disease. Latitude only enrolled high risk disease. Stampede RT2 prostate has OS benefit, and Stampede Abiratron for both low and high volume disease. So these are the different trials and enrollment criterias that have shown benefit. So in conclusion, darolutamide plus ADT significantly improved radiological PFS in patients with metastatic hormone sensitive prostate cancer. Darolutamide showed a benefit across all secondary endpoints. Darolutamide was associated with a deep PSA response regardless of baseline PSA level, and it is the first and only androgen receptor inhibitor to demonstrate clinically meaningful delays in the pain progression, Overall well-being, including the social and family well-being, functional well-being, urinary symptoms, and the darolutamide has also got a favorable safety profile. So darolutamide along with ADT without docetaxel should become an additional standard of care for metastatic hormone sensitive prostate cancer. So with this, I would like to conclude. Thank you, Bayer Pharma, for this opportunity.
Thank you, sir. Thank you, Abhishek sir, for your nice presentation. If there are any questions, you can ask to direct to Dr. Anand sir. So, sir, I don't think there is any questions as of now. Thank you so much, sir, for attending today's meeting and for your nice presentation and all the speakers, you, Dr. Koshal Gupta, sir, and I hope to continue with the same with in future as well, sir.
Thank you so much. Thank you.
Thank you, sir. So, with your permission, so we can conclude the meeting.
Yes, yes. Thank you so much.
So, tech team, we are done with our meeting today.